Welcome to today's OR Today webinar. We have a great presentation featuring Regina Hammond, Senior Manager of Commercial and Clinical Education, and Janet Moran, Senior Clinical Education Consultant for Advanced Sterilization Products. OR Today would like to thank our sponsor, Advanced Sterilization Products. They are a leader in infection prevention dedicated to creating the products, solutions, and processes needed by practitioners to protect patients during their most critical moments. For more information, please visit asp.com. Today's webinar is eligible for one continuing education hour by the Certification Board for Sterile Processing and Distribution. You can obtain your certificate by completing today's post-webinar survey. The survey will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE hour, and you will be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. As I mentioned earlier, our presenters today are Regina Hammond and Janet Moran. They will provide a review of airway devices and their proper handling and associated reprocessing guidelines. They will also touch on some of the challenges and options for reprocessing these devices. Regina and Janet, you may begin whenever you are ready.
Thank you, Jennifer. Good afternoon, everyone, and welcome. On behalf of Janet and I, we also want to extend a thank you for joining today. For the next 45 minutes or so, as Jennifer mentioned, we're going to share information around airway devices. And our goal is to provide you with a few insights and key takeaways that you can leave here with and then hopefully put into practice. So let's review what today's objectives are. We're going to define the terms laryngoscope and bronchoscopes. We also want to identify when and why airway devices are utilized, and review common microorganisms associated with airway devices. We will also be discussing reprocessing options for airway devices, and lastly, discuss the barriers to properly reprocessing airway devices. So let's get started. As you can see and likely recognize from the objectives we just reviewed, we are starting with the basics. We feel it is always the best place to start, as having a strong foundation really helps connect the dots and understand why we need to do things in a specific or certain way. For me, and I'm sure the same is true for many of you, it is always about the why. When we talk about airway devices, you might think about our current state in COVID-19 and everything we are hearing and reading about in the news, the hospital admissions, the patients in the ICU and on respirators. But while airway devices can assist with life-saving measures like these, they are used for a variety of procedures in assisting with the diagnosis, treatment, and maintenance of airways. As we continue to build on the basics, let's talk a little bit about some of the anatomy that makes up our airway. The larynx, commonly called the voice box, is the portion of the respiratory tract containing the vocal cords. It's about 2 inches long, and its cartilage forms what we oftentimes refer to as the Adam's apple. So then, what is a laryngoscope? A laryngoscope is a common airway device that is used for examining the larynx, and it can also be used for inserting an endotracheal tube, or what we may also commonly think of as a breathing tube. There are both rigid and flexible laryngoscopes, and the one that is used is really dependent on physician preference and the procedure being performed. So let's talk a little bit more, and Janet, you can keep it on this slide. We're going to talk more about the different types of laryngoscopes that you may encounter in your practice. As mentioned, there are rigid and flexible laryngoscopes. The rigid laryngoscope is essentially a telescope, and a flexible laryngoscope contains lots of fiber optic strands, and it's made up of different materials and epoxies or glues. And depending on the material used, this will determine whether a rigid or flexible scope can not only hold up to high-level disinfection or sterilization methods, but which high-level disinfection or sterilization modality is used. And as discussed on the previous slide, the practitioner and procedure will determine which type is used. An indirect laryngoscopy is the simplest procedure. So I want you all to think back to when you were a child and visiting the doctor. One of the assessments the doctor likely performed was to place a tongue blade, hold down your tongue, have you say ah, and then inspected the back of your throat. That is when an indirect laryngoscope might be used. Fiber optic laryngoscopy, also known as nasolaryngoscopy, is the most common way the vocal cord or larynx is observed. It can be passed through either the mouth or the nose. A fiber optic laryngoscope or nasolaryngoscope often has no channels, so cleaning and disinfecting or sterilization is really surface related and therefore a more simplified process. Direct laryngoscopy using either a rigid or flexible scope might be used for removal of a foreign body, for example, a stuck chicken or fish bone. This can be considered a medical emergency if there is irritation of the epiglottis, since swelling can lead to airway obstruction. And direct laryngoscopy can also be used to take a biopsy. So now that we've discussed the larynx and laryngoscopes, we're going to next review another airway device, bronchoscopes. Bronchoscopes are used to visualize the bronchus and bronchioles of the lung. A bronchoscope is a thin, flexible instrument with a lighted viewing tube that is used to visualize the airway passages to the lungs. It is inserted through the nose or mouth, or even a tracheostomy, which is a breathing tube that's placed in the throat. Bronchoscopy is used to visualize the inside of the airways for either diagnostic or therapeutic purposes. As we better understand what a bronchoscope is and how it's used, let's chat a little more about rigid and flexible bronchoscope procedures. So rigid bronchoscopes and accessories may come as individual instruments in varying sizes or as an entire bronchoscope set. It is most commonly used for patients with obstruction to either the trachea or the proximal bronchus, and it is typically performed in the operating room or as a special procedure under general anesthesia. The telescope with the attached light cord is inserted through the bronchoscope sheath, and that sheath can have external side ports, which can then be used for things like suction catheters, laser fibers, or ventilation. Water can also be attached, and a biopsy can be taken with a flexible forceps. Although the procedure appears simple at face value, and as you read through steps 1 through 6, fairly straightforward, it is important to remember that anytime one is dealing with the airway, there are risks. So let's talk a little bit about flexible bronchoscopy. The procedure for a flexible bronchoscopy varies a bit, and that really depends on what the objective is. Therefore, it can be as quick as 15 minutes or as long as an hour. The bronchoscope is inserted through the mouth or throat and is advanced down the back of the throat through the vocal cords and into the bronchus of the lungs. So why might a bronchoscopy be done? Well, some of the reasons, as you can see listed here, it might be done to take biopsies, but it also can be utilized to treat infections, as well as remove blockages or address bleeding within the area. So at this time, we want to take a pause and test your knowledge on the information we have shared so far. So your first test your knowledge question is, bronchoscopes are medical devices used as a diagnostic tool to determine, we're going to give you a few moments, read through the answers, and then select the best one. And the answer is D. If you chose D, good for you. A, B, and C are all correct. So now that we know what laryngoscopes and bronchoscopes are and why they are used, Janet's going to take us through a little bit of history and what variables can contribute to an infection when using these devices. Janet?
Thank you, Reggie. Welcome, everyone. Improper reprocessing of these devices in the past has caused news headlines and have influenced current practice for reprocessing these devices. And we'll just take a look at one of these headlines. In 2007, an outbreak of Pseudomonas aeruginosa occurred in an acute care hospital. This outbreak was related to rigid laryngoscopes used to intubate neonates, which were subjected to cleaning but no further reprocessing. The laryngoscopes were originally being reprocessed in sterile processing, but they were getting lost, So respiratory decided they wanted to take back over the practice, but they were just wiping them down with alcohol. The Sentinel event actually shut down the neonatal ICU for this facility, and unfortunately, a couple of babies died. This event and others changed the recommendation for reprocessing laryngoscope blades and handles by the California Department of Health, and eventually throughout many other states in the country. So when you look at the slide, you might be thinking, well, these happened a long time ago. But Reggie, a little later in the presentation, is going to go over a 2018 study by Corey Ofsted that really highlights that there's still some problems out there. The two most common organisms that cause infections related to bronchoscopes are Pseudomonas aeruginosa and Mycobacterium tuberculosis, or TB. Pseudomonas aeruginosa can be from either an endogenous, meaning the patient themselves, or an exogenous source. An example of an endogenous infection is Pseudomonas aeruginosa resulting from aspiration of secretions in a sedated patient during a flexible bronchoscope. An example of an exogenous, preventable infection during bronchoscopy is Pseudomonas and Mycobacteria being transmitted from one patient to another by a contaminated endoscope or its accessories. So Pseudomonas aeruginosa can cause infections in the blood and lungs. We know that as pneumonia. If the patient gets septic from this organism, it can even cause death. And we see that that's true for another opportunistic organism. If you look to the left column, third one down, S. marcescens, which is Serratia marcescens, can also cause bacteremia, sepsis, and death. So I don't know if you're familiar with William Rutala, but William Rutala is national, if not world-renowned epidemiologist out of North Carolina. And he and Weber wrote a book, Sterilization and Disinfection, in 2008, and it's still on the CDC website. It since has been updated to 2013, but it's still available to anyone who goes to the site. Anyways, in 2008, they identified the different microorganisms and the resistance to the different methods of reprocessing. Resistance determined the guidance for where the devices fell. For example, low or medium level disinfection, high level disinfection, or sterilization. If we look to the left of the slide and we see on the bottom it says susceptible, those are the most susceptible organisms to the process. If we go to the top, it's the most resistant. So let's just start at the bottom. Lipid or medium-sized viruses would include herpes or the coronavirus. Then we have vegetative bacteria, which would be Pseudomonas aeruginosa, and we've talked a little bit about that already. You have fungi, non-lipid or small viruses such as polio, mycobacterium such as TB, cryptosporidium, and then you have your bacteriospores. The example given here is Bacillus atrophius, but you may be more familiar with one that you're using on a daily basis for your test packs, your process challenge devices, or your BIs that are used in steam sterilization or low temperature sterilization. So that's Geobacillus stereothermophilus. When we look to the right, this isn't to scale, but when we're talking about destruction of microorganisms, and we think about high-level disinfection. High-level disinfection kills everything but some bacterial spores, whereas sterilization kills everything, including bacterial spores. Well, you're probably thinking, well, what about prions? Well, prions are in a class by themselves. Prions are associated with Creutzfeldt-Jakob disease, or CJD. You may have heard of mad cow. And if you have a patient who's suspected of having CJD, you do want to follow your policy and procedure for reprocessing those devices, which is most likely based on the WHO recommendations, so the World Health Organization. So that's another topic for another day. In 2015, the FDA estimated 500,000 patients receiving bronchoscopes for diagnosis of conditions affecting the airways and lungs. And I suspect the number has gone up in 2020, especially with all the respiratory symptoms associated with COVID-19. The FDA also identified 2 factors that can contribute to infections associated with bronchoscopes. 1, not meticulously following manufacturer's instructions for use. And 2, using devices that are damaged. Now, being a seasoned OR nurse, I can tell you that ORs are notorious for having old bronchoscopes that may have been, they may have not been used very often, but they're still in circulation. But just so you know that both time and how they're used and usage may affect material integrity of these devices. In 2015, the FDA released a safety communication titled Infections Associated with Reprocessed Flexible Bronchoscopes and identified missteps when reprocessing these devices. The missteps included lack of pre-cleaning, also known as point-of-use cleaning, failure to perform thorough cleaning, failure to brush or flush all the channels, use of expired detergent or high-level disinfectant, insufficient flushing, rinsing, or drying. So looking at the slide, why might these steps have occurred? Well, possibly because of lack of education. Are the people who are doing the process, are they trained? Do they have competencies? Are those competencies being kept up? Staff's perception of the risk being low for transmitting microorganisms. Maybe you've heard this once or twice. We've always done it this way, and we haven't had an issue. Inadequate resources. Inadequate resources can be people. So are the people who are doing the reprocessing, do they have competing priorities? Are they trying to take care of patients as well as reprocess scopes? Or it can be tools or space or workflow. And then lack of supervision. Joe's better than Susie. Susie's known to take shortcut. A friend of mine tells a story of when she was a GI manager. She had a technician who was the fastest for manually cleaning flexible endoscopes. The staff loved it when she was on because they knew they would get their scopes back quickly. But the manager realized that, well, that wasn't necessarily a good thing. So one day she did go to observe the technician, and sure enough, she was missing some steps. Lack of maintenance on the device. Remember, these devices are black and fairly complex. Don't assume just because a bronchoscope is working, it's safe for use. There are many variables that can affect a bronchoscope's integrity. And what's one of those things? Biofilm. Biofilm's an assemblage of microbial cells that is irreversibly attached to a surface and in a matrix of exopolymeric substances. Now that's a mouthful, but basically it is bacterial colonies with other substances that are encased. But something you might relate to a little better is plaque on your teeth. So plaque on your teeth is an example of biofilm. This is why you go to the dental hygienist twice a year to get it removed. If the biofilm's not removed, gum disease can ensue and possibly even an infection. When microorganisms form biofilms, they can survive under conditions of drying, chemical exposure, and antibiotic exposure. The best way to deal with biofilm is to prevent it from occurring, and this can be accomplished by proper reprocessing and maintenance of the flexible scopes. So let's go ahead and test your knowledge. Name at least 2 factors that may help explain infections by bronchoscopes. And we'll give you just a few seconds on that one. And the answer is E. Now for this next section, Reggie's going to go over Spalding's classification, some of the professional guidelines, as well as do some highlights on that Corey Ofsted study. Reggie.
Thank you, Janet. Excuse me. I know that most of you are likely familiar with Spalding's classification, but as I said in the beginning, going back to the basics and building from there is always a good idea. And as Spalding's classification is the criteria still used to determine how items are processed, we feel it is important to review. Spalding's classification has been around since the 1960s. It is this classification system that identifies how a device should be reprocessed based on the risk of infection it may cause. And based on that, Spalding then placed devices into 3 categories. And what are those categories? Well, as you can see, we have critical, semi-critical, and non-critical. Critical devices are those devices that enter tissue or body cavities, so a sterile area. An example of a critical device is a choledocoscope or a biopsy forceps. Sterilization is the minimum reprocessing modality that must be used for reprocessing these devices. Semi-critical devices, on the other hand, are those that come into contact with mucous membranes. And an example of this might be a flexible endoscope. So high-level disinfection is the minimal method for reprocessing these devices. However, and it is important to note, depending on the device, it may also be validated for sterilization. And we know this can be confusing, so just to walk through a scenario that many of you have likely encountered as part of your workflow and in your workplace. If you are using forceps to take a biopsy, it penetrates tissue, and that does require sterilization. But the endoscope being utilized during the procedure is traditionally classified as a semi-critical device, and so only requires high-level disinfection. So I think this is just something that we all should be aware of and be thinking about as part of our practice. And lastly, non-critical devices are those that come into contact with intact skin. So a blood pressure cuff or even a bedpan, those are both examples of non-critical devices that require a minimum of low or intermediate disinfection. As Janet mentioned earlier, we want to review a few of the organizations that are involved in developing the standards and guidelines we use or should be using as part of our practice and as it relates to the reprocessing of these devices. So let's start with HCPAC. HCPAC is a federal advisory committee who provides guidance to the CDC and the Secretary of Health and Human Services. And as you can see, it is well represented. You have agencies and organizations from across the healthcare continuum as members and who are involved in providing guidance and recommendations that get put forward. The committee's focus is on practice and strategies for surveillance, prevention, and the control of healthcare-associated infections, and something again that we commonly refer to as HAIs, as well as antibiotic resistance and related events in the United States. The organizations and agencies listed here were tasked in 2018 to provide guidance on ways to improve facility-level training and ensuring competency for reprocessing endoscopes. We can all agree that this was likely no small task, but I think as we reflect back on some of the statistics Janet shared earlier, we definitely recognize the need. So what about professional organizations? For example, AORN. AORN sits on task forces and committees for various organizational agencies like the previously mentioned HCPAC, but they also provide individual guidelines for clinical practice. As it relates to semi-critical devices, AORN has a guideline stating reusable semi-critical items that are manufacturer validated for sterilization should be sterilized if possible. So, if and when you have a higher level of reprocessing available to you and that device has been validated for that higher level of reprocessing, the recommendation is to use it. And while it's not listed here, AAMI Standard 91 states that when possible and practical, flexible and semi-rigid endoscopes should be sterilized due to the greater margin of safety built into sterilization. So moving from professional organizations to 2 key opinion leaders that Janet previously mentioned, and again, many of you are likely familiar with, Dr. Ritala and Weber. According to Ritala and Weber, most infections associated with reprocessing of medical or surgical instruments involve high-level disinfection of semi-critical devices. And I think we've all heard the statement, there is a very small margin of safety when it comes to reprocessing endoscopes. And again, I think we just need to think back to the comments I made around AAMI Standard 91. And part of why they likely have made that recommendation around sterilization due to the greater margin of safety built into sterilization. Because of some of these recent articles and studies, a question that is now sometimes asked, is it time to change Spalding's classification? And while that's not a point of discussion for today, it is something that you may hear about or have already heard about and discussions you yourself may be involved in. So we just wanted to give you a little food for thought. Another point Ritala and Weber make is that although not all states require high-level disinfection or sterilization of laryngoscope handles, there have been reports of potentially infectious agents being left on what we consider or label ready for use handles. And those infectious agents include blood, Staph aureus, and Acinetobacter. And again, I think we only have to go back to Janet's previous comments about the NICU and the use of contaminated handles and blades and the consequences that occurred. Some things to take note of when we're processing laryngoscopes, and I think these are things that we all need to be thinking about. If both the laryngoscope blade and handle are sterilized, they need to be checked for function prior to use. In addition, even if a protective sheath is used, laryngoscope blades and handles should be sterilized or high-level disinfected regardless. And lastly, the Joint Commission states, after high-level disinfection or sterilization of laryngoscope blades and handles, they must be packaged in a way that prevents recontamination. As Janet also mentioned, we want to spend a little time sharing information around a recent study Corey Ofsted published. In 2018, Ofsted published a study that evaluated the effectiveness of bronchoscope reprocessing. And in the study background, it identified that pathogen transmission occurred even when reprocessing policies were in place and even when cleaning and high-level disinfection occurred. So even when a policy was clearly outlined and thought to be followed, transmission still took place. Just to give you a bit of background on how this prospective study was conducted, it was a multi-site study. It involved the examination of 24 clinically used bronchoscopes. It used a systematic approach with direct observation, and it also used visual inspection. And that visual inspection was done with lighted magnification and borescopes, as well as ATP testing to detect contamination. So what were the results of this study? Well, the results of the study are actually quite startling. 100% of the scopes had residual contamination after cleaning. Microbial growth was found in 14 or 58% of fully reprocessed bronchoscopes. And irregularities such as retaining fluid and residue, as well as scratches, damaged insertion tubes and distal ends, as well as debris in channels, was found. And lastly, this study identified substandard reprocessing at 2 of the 3 sites they visited. The conclusion was that there were contaminated bronchoscopes at all sites in the study, and that inadequate reprocessing practices may have contributed. And I think more importantly, even when guidelines were followed, high-level disinfection was not always effective. Based on all of these findings, Ofsted's final recommendation is a shift towards sterilization of bronchoscopes. And I just want all of you to think back to some of the previous slides and the information that we've shared with you, the recommendation from AORN, as well as AAMI, and the fact that many devices may be validated for more than one processing method, meaning both high-level disinfection and sterilization. It is always best practice to know what the IFU states for a device, and based on your own department's risk assessments, make well-informed and evidence-based decisions. So Janet, I'm now going to hand it back to you, and Janet's going to not only take us home, but she's going to go through some of the essential steps required when reprocessing a flexible bronchoscope. Janet?
Thanks, Reggie. Do you have the tools to do the correct job of reprocessing laryngoscopes and bronchoscopes? I was in a decontamination room, and a registry technician was working that day. And he was cleaning a flexible bronchoscope for sterilization. I noticed he had not leak tested the device or used proper size brushing for cleaning. When I asked him about it, he stated, "I know what I need to process this scope, but they don't have what I need, so I'm using what I have." So here we have a technician who's knowledgeable, but continues with the task even though he knows it's being done incorrectly. Remember in the previous slides talking about the tools and supervisions being factors that can be lacking for properly reprocessing these flexible scopes. The steps to reprocessing any flexible endoscope are complex, but they're essential. So let's walk through some of them. Pre-cleaning or point of use cleaning needs to be performed immediately following the use of the scope, wherever that occurs. What is used is determined by the scope manufacturer's IFU. However, professional guidelines do give some general guidance as well. The basic steps for pre-cleaning a flexible bronchoscope, for example, include wiping down the external surface and suctioning through the suction biopsy channel. And should that scope have another channel, you want to suction through that as well. Make sure that you mark the time the pre-cleaning takes place, because for some scope manufacturers, there's a time limit from the point of use cleaning to manual cleaning. And if you don't meet that time limit, you have to do an extended reprocessing on that. When transporting the scope, use a container that is leak-proof and puncture resistant. Label the transport card or container as a biohazard, and that's a regulatory requirement. There should be a receiving area on the dirty side of the decontamination room the scope is taken to. And then leak test that scope in accordance with the manufacturer's instructions for use. I recently read an article in AORN that highlighted the importance of leak testing. And one of the scenarios given was not having a way to measure the amount of air that should escape the pin on the leak test connection itself. So one of the technicians was doing a quality improvement project and noticed that the air coming from their leak tester seemed kind of faint. So he called on a couple of technicians who worked in the room every day, but they said, no, the air is adequate. That's how it is. He went to the manager and asked her to purchase a new leak tester. When they received that new leak tester, the air coming out was much more robust. And so they did find out that that device was actually indeed defective. This is just an example of one of those small variables that can impact the success of reprocessing a flexible bronchoscope or laryngoscope. And then, of course, if the scope fails the leak test, remove it from service. Manual cleaning. So manual cleaning is the most critical step. Follow the scope manufacturer's instructions for use. Always use a freshly prepared cleaning solution. Use the cleaning solution in the correct concentration, temperature, and designated time. One of the things that I see quite a bit is that people will measure out the water. They may have a line in the sink or whatever, and then they add the correct amount of detergent or enzymatic. So everything looks good. The ratio is great for the scope cleaning. But then they go to the shelf and they grab an enzymatic impregnated sponge. So now you just disrupted that ratio. So the thing about cleaning solutions is that they can adhere to the scope if you use too much, and they may not be effective if you use too little. So the analogy I like to use is going to the restroom and I wash my hands. I put a little too much soap on my hands and I do my 20-second rinse, but I'm kind of in a hurry. So after the 20 seconds, I grab a towel, dry it, and then I touch a surface and it's sticky. So the same thing can happen to your scopes. And if a detergent or enzymatic adheres to that scope, it can impede the effectiveness of a high-level disinfectant or a sterilant. Use a clean brush for each scope cleaning and use the appropriate size for the channel being cleaned. Rinse and flush the channels meticulously. After manual cleaning, visually inspect the scope and accessories for cleanliness, missing parts, lens clarity, integrity, moisture, and function. Most facilities, in addition, are using some type of cleaning verification test after the cleaning. All of these steps should take place prior to either high-level disinfecting or sterilizing the device. And sometimes I get pushback about sterilization being so much more difficult, but when you look at it, many of the processes or steps are consistent for both up until a certain point. Always reference the manufacturer's instructions for use for determining which modality can be used when reprocessing the scope. Following high-level disinfection, you're going to want to use alcohol following the manufacturer's instructions for use. Typically, it's 70 to 90% isopropyl alcohol. The function of alcohol and using alcohol is that it facilitates drying. It doesn't dry the scope, but it facilitates it. Studies have supported the use of flushing alcohol followed by forced air drying as a method to prevent microbial growth in high-level disinfected scopes. And we're not talking about the air you get at Home Depot or Office Depot, that canned air that you clean off your computer. Those all have oils and contaminants in them. And don't laugh, because I actually have seen that. What I am speaking of is instrument air via a tank or a centralized access line or some other source. There's not a consensus on length of time a flexible endoscope can be stored after high-level disinfection. And it really is dependent on a risk assessment and the professional guideline that the facility is following. It is recommended, however, that the scopes do not touch the floor of the cabinet and that they never be stored in the original shipment case. Always wear gloves when handling clean scopes. And I would just add to that, just always wear latex-free gloves whenever you're handling a scope. And have a method in place for identifying whether that scope's been reprocessed, because you certainly wouldn't want to use a contaminated scope on a patient. Documentation is essential for quality assurance and patient tracing. So HICPAC has an audit tool on the CDC website that outlines what should be included in this. And this is available to anybody who goes to the CDC website. And what they've listed are date and time, ID of the endoscope and accessories, method of verification of cleaning and results of cleaning verification test, number or identifier of the reprocessor or sterilizer, results of efficacy testing, so that would be your test strips, identification of persons doing the reprocessing, who's putting it in, who's taking it out, lot number of the processing solutions, disposition of defective items or equipment, and maintenance of water systems. And I just want to stop here because this is an area that I see some facilities having deficits in. And if you're using an AER, automatic endo reprocessor, you're going to have wall filters and you're going to have internal filters. Typically, I see the wall filters changed out by biomed or facilities, and they should be keeping a log on when those are changed out. But if they're not, then you should be keeping that log. For the internal filters, if they're only being changed out when they do preventative or corrective maintenance, then that should be part of that record. But if the end user is changing those out, you want to make sure that you're capturing that on a log, as well as writing the date that they're changed out on the filter itself. Then endoscopes and endoscope accessories, what your current list is, what's gone out for repair, what's been retired, and processing equipment. So this would be record of preventive maintenance on your equipment as well as corrective maintenance. So having that handy. This information, again, is available on the CDC website. So let's talk a little bit about manually high-level disinfectant. I associate manually high-level disinfecting with IUS, immediate use steam sterilization, or flash sterilization. You're like, what? How do those two relate? Well, meaning you only do it when there's no other option. Well, why? Because of the challenges. Number one, there's no automated steps. And two, every step is dependent on the technician completing the steps correctly. So it's very subjective. Some of the challenges that I have personally seen are proper testing of the high-level disinfection solution, maintaining the high-level disinfection solution at the correct temperature, proper rinsing, and if you don't properly rinse, the chemical stays on that device, and then the patient's exposed to it, and they can actually have an adverse reaction to it. Having the space to do the manual reprocessing and to support a workflow of dirty to clean. So if you're using manual reprocessing for your laryngoscopes and bronchoscopes right now, just kind of take a minute and think about things and what you're doing, how you're doing it. Some of the considerations of whether you want to manually reprocess these devices are the following. The number of devices and the complexity. For example, ensuring channels are filled with a high-level disinfectant on devices can be challenging when you're doing it manually. Do you have a way to monitor the time and temperature of the high-level disinfectant? How is the high-level disinfectant going to be tested for efficacy? Will test strips be used, or will it be an automated system? Will the rinsing of the device be done properly? Is there the space and setup to do it? Is the manufacturer requiring a sterile water rinse? Manual documentation will need to be performed. Can you capture and ensure that it's done correctly every time? Anytime we can automate the process, decision-making or subjectivity gets removed. The same general information applies to automated processes as it does manual process. Some of the considerations are the volume of scopes that need to be processed. Is there a location that can be dedicated to this task? Do you want a single shot, high-level disinfectant where you're getting a fresh solution each time? Or are you okay with a reusable that expires with time or efficacy? And I've seen the time be as short as 5 days to as long as 40 days. Does the system allow for minimum contact points, ensuring the high-level disinfectant reaches all surfaces? Are test strips needed to check the efficacy of the high-level disinfectant prior to each use? Are there quality control checks to ensure the test strips are performing correctly? Is the system a closed system for vapor control, meaning that you're going to have minimal exposure to your staff of the chemical? What needed documentation is being captured on the printout? And if it's not being captured, do you have a way to capture it? Is there a self-disinfect cycle, either thermal, meaning using hot water, or chemical, available to prevent any bioformation in the internal components of the AER? Terminal sterilization using low temperature hydrogen peroxide gas plasma provides the greatest number of quality monitors. These quality monitors are physical, chemical, and biological. The physical is the printout that lets you know the sterilizer parameters have been met and the cycle has completed. And the chemical is your internal and external indicators that let you know that the sterilants reached that particular area. The biological indicator is the closest thing you can use to confirm sterilization because of the destruction of the bacterial spores. Terminal sterilization does have some convenience because you get a packaged product that can go on the shelf or you can use it immediately. It also provides that sterility assurance level of 10 to the minus 6, meaning that there's just a chance in a million a microorganism has survived. However, just like the other two processes, there are some considerations. Is the device validated by the manufacturer to be terminally sterilized? Remember, we had talked about old bronchoscopes, and they may not be materially compatible with terminal sterilization. Is there dedicated space to clean, dry, and package the devices? Is there storage space? Documentation, what will be used? Will you do a manual log, or will there be an automated system using instrument tracking or another automated system? So what are your thoughts about these three options for reprocessing these devices? One, I'd love to hear, or we would love to hear what you're currently using, but also what your thoughts are about even changing your practice in the chat room. So let's go ahead and test your knowledge. Sterilization provides the greatest assurance that an item is safe to use on a patient? And the answer is true. It does provide the greatest assurance that an item is safe to use on a patient, and that's because of those quality monitors. So in conclusion, we've learned that what laryngoscopes and bronchoscopes are, how they're used, and challenges that are presented when reprocessing these devices. Inadequate reprocessing, as well as other variables, increases the risk of infection to our patients. So there are many things that can be done to prevent infection when reprocessing these devices. For example, and we went over and over this throughout this presentation, number one, following the manufacturer's instructions for use. Number two, automating the steps whenever possible, because that takes the subjectivity out of the process. Number three, including quality monitors to support compliance. No matter what your reprocessing practice is today, know that with time, technology changes. Certainly when I started out as an OR nurse, things were quite different than they are today. But with time and technology, we can improve the way we do things to ensure patient safety, so we only get better. As Florence Nightingale said, it may seem a strange principle to enunciate, as the very first requirement in a hospital, that it should do the sick no harm. Remember, you are one variable that can make a difference in keeping your patients safe. I think we're ready to roll into the questions, Jennifer.
Thank you so much to ASP for this presentation. We do have a few questions that have come in, and thank you, Janet, for turning on your webcam so we can see you.
Yeah, my pleasure.
Our first question is, can all laryngoscope handles be sterilized using low temperature gas plasma sterilization?
Reggie, did you want to take that one? Or?
Yeah, sorry, I was trying to get my webcam on. Now I'm experiencing some technical difficulties. But yes, absolutely. So I think that, you know, as we were talking about during the presentation, manufacturers of laryngoscope blades, depending on the materials that they use, and that can vary widely, that impacts how you ultimately can process those. So just to give an example, for most laryngoscope handles, the batteries need to be removed, but there are some that you can leave the battery in. So it really is about following the manufacturer's instructions for use.
Jennifer, are there any other questions?
What are my options if I don't have access to compressed air and can't afford a forced air endoscope storage cabinet?
Yeah, drying of scopes is a very hot topic, and I do find many of my customers have challenges with having a source to dry with. If you can't get instrument air quality instrument air to help dry those scopes, there are some other options out there. And I don't want to name specific devices, but one comes to mind where you can actually attach it to an IV pole, and it has disposables connected to it that can connect to the channels on a scope and help with the drying process, as well as there are cabinets now that have that same option as well. So there are some options out there for everyone, and I just want you to think about the scientific evidence behind drying those scopes. It's not something to ignore, and it is a very important part of scope reprocessing.
Okay, great. Thank you so much, Reggie and Janet, for a very thought-provoking presentation. I would like to encourage everyone to visit today's sponsor, Advanced Sterilization Products, to learn more about the products they provide to our industry. Please visit asp.com. A quick reminder that you can obtain your certificate by completing today's post-webinar survey. The survey will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE hour, and you will be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. We will be back soon with another webinar. Please visit ortoday.com/webinars for more details and complimentary registration. Thank you all and have a great day.
Thank you, Jennifer.
Yes, thank you, Jennifer.